Hi, everyone. Welcome back to segment 2. For segment 1 went really fast. I mean,
sure
time
did.
flies when you're having fun and when you're talking about really important things. So in this segment, an homage to our lovely guest, I have decided to wear this shirt. And it says, I've got your back. And I think he's got a lot of people's backs.
He sure
we
does.
have people's backs. And, we're going to get into talking about something that's near and dear to our heart right now, which is bone health and bone health analysis and REMS.
You bet. And what is REMS, Meg? Before we get on, because Dr. Sinicropi has now been introduced to the REMS technology after meeting us, which is an honor to be able to, give this information to a renowned surgeon like him.
Yep.
So as a sonographer, let's talk about what is REMS.
You're going to make me say the long word,
I
aren't
am.
you? Yes.
I absolutely am.
So REMS is short for radio frequency echographic multispectrometry. And I think we should run a contest and see if people can say it 5 times
I always
fast
get it wrong.
and not trip up, right? Yeah. So basically what it means is it's an ultrasound-based test that allows us to process raw data signals from the bones so that we can look at not only bone quantity, but bone quality. And that's really what's the game changer in the bone health here. So in this segment, we really want to focus on talking about changing the conversations that we have about bone health, because bone health is not just about bone sickness. So we want to start talking about our bones and how we can support them before you get to the place where we're talking about osteoporosis.
Or
That's
where you're
scary
seeing
word.
him in the surgical suite because you've actually have a broken bone.
Yeah.
And that generational conversation can happen because REMS with no radiation can be done anywhere. And 21 and older, Dr. Sinicropi, what did you think about that when you first heard about this new REMS technology from your lens as a spinal surgeon who's fixing people once they're broken?
Yeah, I think it could not be, coming at a more opportune time. I think we really need to be much, much more keenly aware of bone health and what the long-term ramifications are. Sometimes if you tell somebody, hey, don't eat all this sugar, you might feel a little bit better tomorrow. That might have some effect, but they say, you know what? I really like my Kit Kats though. I'm not going to change just so I feel 10% better tomorrow. If you tell somebody, hey, if you keep eating those Kit Kats in 10 years, you're not going to have any legs. That's a more effective thing. I'm not trying to be alarmist, but it is just true. So what I'd like to share to your audience is, I'm a spine surgeon and we cover a bunch of different hospitals, but one of them is a level 1 trauma hospital. One of them is a level 3 trauma hospital. Level 1 meaning we see horrifics. I mean, that means the helicopters are coming in and people are really, really broken, extricated from cars, things like that. But in both of those hospitals, I can tell you that our census as a spine and neurosurgical clinic is filled with people that have osteoporotic compression fractures. Some are minor fractures that can be treated with just bracing and not doing much. Some are multiple osteoporotic compression fractures, which can become unstable or collapse. People become deformed, they're misshapen, and then we are in a bad conundrum, and that's this. Their bone quality is so bad, but yet it's actually dangerous for them to even stand up. And so now I'm a surgeon that has tools like putting in dozens of screws in your body, putting cement and fixing everything and doing all these things, except I don't even know if it's going to hold because the bone quality is so poor. Recently we saw a couple of honestly disasters, people that it was so bad, their bone quality, we had to opt not to do surgery because there was literally nothing we can do. And we have to have tough conversations with families saying, I'm really sorry. This is something that there's no, it's like, imagine putting a screw in butter. It doesn't matter, right? It'll move in an hour. There's no point of even going there. So you could do some vertebroplasties or putting cement in the bone and things like that. But when they're unstable, all you can do is keep them on bed rest. And I can tell you for elderly folks, just being on bed rest for a long time, nothing good happens medically. And so what I want to say on that is at least the clinic that we are a part of. From day one, I've had a partner, Dr. Glenn Butterman, who has written a lot. Actually, he's nationally published, renownedly published, actually, and he talks about bone health. So from the beginning, I was always into, bone health. We always manage people with vitamin D and calcium and get them in for DEXAs and things like that. But sadly, unfortunately, by the time that the spine surgeon oftentimes is even doing it, it's either because we're about to do surgery on them, and then we pick up that their bone health is horrible, and then the only option we have at that time, because they need surgery sooner rather than later, is to get them on some type of medications, injectables, whatever the endocrinologist wants to do. Or again, we're seeing them with fragility fractures where their quality of life has already been compromised. And so I am so excited to be getting more and more into the preventative bone health space, which is really what we can honestly say, it didn't have to be that way. Telling grandma when she comes in, it didn't have to be that way. Guess what? It doesn't help grandma. Now, it might help her daughter or her grandkid, but it doesn't help her. Other than, we can do what we can do at that point. And obviously, there's a lot of treatments that we can do for people once they get osteoporosis. But like other chronic diseases, diabetes, Alzheimer's disease, cancers, all these other things, so much of it is preventable, but we don't think that way as physicians for whatever reason. We think, what procedure and what medication can we give these people after the fact? So I just want to say a big thank you for what you guys are doing with your tour across Canada. We got to do one in Minnesota. We just talked about that before. But everything you're doing to put overall bone health on the map, and I hope to become really a torchbearer in promoting bone health and helping to really promote things like the REMS bone scan and bring that really nationally far and wide in our country. It's so important.
It's really going to change the conversation. I mean, it's interesting that you went from, the grandma to the mom to the daughter. And I mean, we know it's not just a disease that affects females, but we're on a mission to try and flip that so that we are talking, most of the people that we see are in their 50s, I would say 40s to 60s. And, so they've got daughters, they've got grandkids too, plus they have a mom, right? So being able to transcend those generational boundaries and have everybody come to the table and talk about it at the same time is so crucial. And we are at this very, very unique period here where we have this really unique opportunity to be able to make a big change in the way we look at bone health. And to be on the cusp of that, to be on the front lines of that is just so amazing. And
it's an honor.
It really is an honor and a privilege to have people trust us because we know this is new. Yeah. So, when you were talking about some of the disease processes, in terms of diabetes, and this is why I wanted to shift our talk to, everybody is afraid of the word osteoporosis. I want to shift the thought about bone health to the strength portion, right? So, we have women going for DEXAs who don't end up being in that osteoporotic category, but they come to us and they are in the osteoporotic category. But that's just one piece of the picture, right? It's just one piece of the puzzle. And when we look at that, we're able to get that bone strength. It's amazing. But alternatively, we have people coming in who would have had a DEXA, who, let's say they're diabetic. This is close to your heart. They're diabetic. They've had a DEXA. Their bone density is normal. So you think, okay, great, I can walk away. I'm good. But then I scan them, and their bone quality is terrible. And that is where we're missing the boat here. So I've talked to Marg about this. I try to pull away from using the word osteoporosis too much because it is surrounded in so much fear.
There's a lot of fear.
So we're talking about, we start to talk about, it would be really great, and maybe you can help push this forward, where we talk about, instead of using the word osteoporosis, we're talking about bone loss. And are we normal? Are we normal to moderate bone loss? Are we moderate? Are we moderate to severe? Are we severe? So we've got those categories, and then we're matching up the fragility scores and the bone strength with those different categories to get a better picture. So we're not just focusing on when you're seeing people at the end, we're focusing on, what can we do if you're in this area.
Well, and that preventative and patient empowerment piece, when we understand bone quality, we lose bone as we age. That's part of aging. But bone quality we can impact into our 60s, 70s, 80s, and 90s, and that's lifestyle. And the REMS picks up that. So when we're going to your hypercharge clinic and having, in the next segment, we're going to talk about all the various things we can do proactively, what's in our musculoskeletal toolbox, nutrition and exercise and all the things. But this gives us a picture, so when people can actually see, well, hang on a minute here, I may have bad bone quality, and what does that mean or not mean for me 10 years from now? I can get into action today to change that bone quality and to prevent fractures so that we're not in your OR. And that impacts, which is something we're both passionate about, the strain on our healthcare system, which is immense, or falls and fracture prevention, which strains our systems financially. I know you agree with this.
Oh my God. I mean, the cost, we can't even, I mean, there's numbers thrown around. The billions and billions of dollars of cost to the healthcare system from fragility fractures is massive. We just talked about spine fractures. Our entire board in surgery in the afternoons is filled with all the hip fractures that come in. And it's all because of, bad bones. I mean, if they had great bones, they'd fall and not fracture, right? We know this. The other thing, diabetes, metabolic dysfunction, we have to think about it differently. First of all, it is a big package. We're thinking about it wrong. If people are metabolically unhealthy, they're metabolically unhealthy. It affects everything. It affects your brain, your liver, right? Non-alcoholic fatty liver disease is off the charts. And it all started after the change in high fructose consumption. There's all these theories about fructose and the cause of this non-alcoholic fatty liver disease. We don't even talk about that. But having these poor lifestyles, toxins, the way we live our lives, uncontrolled fight or flight catecholamines in our system constantly, they not only affect, everything, it affects bone. And so if I see patients now with my different mindset that have diabetes, they're obese, they're all these other things where their metabolic health is poor, then automatically I'm already thinking about their bone health now. Because it's one big system that's all tied together. Compartmentalizing all these systems and saying, well, this is separate from that is such an old way of thinking about stuff. We need to take those old models and throw them away because they're just wrong. Okay. And so one of the other thing before getting into the REMS that I kind of want to get out to the audience is how wonderful it is. And I know you guys are excited about this. If you have a patient sitting across from you and you do a REMS bone scan and you pick up their fragility fracture, it's almost like a movie. Because if you could pick, those movies where you can go into another dimension or another time or another space, you can see that 40-year-old or that 30-year-old as a 65-year-old falling and breaking their hip or having a spine. And then you pick them up on the REM scan, they change their whole life. And then you go back into that, that time portal and they're doing great, right? They're vibrant, they're playing softball, they're doing all these other things. This is how much of an impact we make by prevention. And so we've got to get out of the mindset that we're not just making impacts when we're putting screws in people or taking out that disc herniation. We are making impacts by just saying a word to you need to check your bone health. That might change the trajectory literally of their entire life. That to me is why I want to be at the forefront of this preventative health movement. FAM.
Yes, that's
You're going to be part of the family.
You are part of the family. You're officially part of the family. And yes, you're so right. We're gonna have to go to the next segment here in a minute, but it's so important to hear and so refreshing to hear somebody so esteemed as you with your background to recognize that we can do this differently. And, when we look at bone health and prevention, there's a lot of fear around this. We're seeing and being heard. We're seeing people in our clinics on a daily basis that are tearful because they thought they were going to retire in golf and enjoy life. And instead they're being told, don't, your DEXA says your bone mineral density is minus 2.5 or greater. You're going to fracture. Their life is over.
You're going to fracture and you're going to die. That's what they get.
And they don't even know the full comprehensive picture of their bone health. And that bone quality and the fragility risk fracture score is a game changer. But what's more of a game changer is the empowerment piece for the average person, because now, as you said, that movie, when we fast forward, we can change that. And we're seeing that now a year and a half in, where people are coming back when they've put in the work. And that's what the next segment's going to be about, are those tools where they come back and they can literally see in the report how they have changed through their actions. Their fragility risk fracture score, their bone quality has improved, and the REMS is sensitive to pick that up. Whereas the DEXA, which for 40 years, this is what's been the only, we're the new kid on the block. This REMS is the new kid on the block, and it's time to be open. There's a place for both, but we need, as you said, to be open to the reality that this can be. So we're going to be back here in a minute. We've got so much more to talk about. So after the break, we're coming back. What's in your musculoskeletal toolbox? Well, wait till you hear some of the things Dr. Sinicropi is doing in his incredible hypercharge clinic. Stay tuned. We'll be right back.